Inhalation burns, intubation, rock versus sucks, all on today's episode of Viral Unpacking. Let's go. Hey everybody, welcome back to another episode of Viral Unpacking. Today is another medical topic. We have our friend Shade Tree Cardiology. Again, one of my favorites that we've mentioned. If you're not following him, please go to TikTok and his other socials. He's got a lot of great advice and information. He's a cornucopia of knowledge when it comes to paramedicine. It's like, how did you get that smart kind of level? So very impressive guy. And today he's looks like he's leaving the gym, just banged out a workout, and he is going to talk about one of my favorite topics to really get into a debate on. And he gets into, somebody asks a question about, best way to intubate a burn patient who's alert. And so he answers a little bit of rock versus sucks and a little bit of burn and inhalation. He gets into that a tiny bit. So I just wanted to expound a tiny bit, and then, I texted him and let him know that I was going to pick his brain about it later. So let's go ahead and jump in and see what this video is all about.
What will be the best way to intubate a burn patient who's alert yet has inhalation burns and you're about to lose the airway? Shit, I dropped my keys. I really need to let him fix the discs to my neck. My hands go numb. So this was in reference to worrying about hyperkalemia, I'm assuming. So immediately post-burn, there's not a huge potassium shift. The fluid shift in burns takes about 24 hours to become mostly complete. This is why, like your Parkland and your Universal formulas and your Brook formula, they work around that first 24 hours.
So, perfect. So the question that the answer he's given, he's assuming that the patients really want to know, what paralytics to use in RSI. And so, of course, the hot topic with that is succinylcholine, and succinylcholine has a bunch of contraindications, and some of them, or the one he brings up, is burns. So typically that fluid shift that allows, so as your tissues break down, and fluid shifts out, with that becomes, some potassium, and that you can have some hyperkalemia into the vasculature over time, or at least higher levels of potassium in your blood. And then if you give succinylcholine, the potassium could spike. And the reason it does that is because, remember, succinylcholine versus rock and Vec and the old dinosaur Pavulon and some of the others, sucks versus those are depolarizing via, i.e. sucks, and non-depolarizing the others. Now, the depolarizing is the piece. You have a nerve that comes down, and then the muscle underneath in concept. And so acetylcholine, typically on any typical day of you go to stand up, or you're using your thumb right now to change the screen. Or to tell me to go faster, slower, or to swipe. Your muscles have to be activated, of course, depolarized, and your skeletal muscle in your thumb, that's what happens. So normally, acetylcholine gets to the end of that nerve terminal and is released and crosses that motor end plate, finds an acetylcholine receptor, sits in it, and the action potential is generated. The nerve now can contract, and because of that acetylcholine into the acetylcholine receptor, a tiny bit of potassium is released. And we need just it's with the heart, it's all or nothing. With action potential and nerves and muscles, it's all or nothing. Once you start an area, it spreads out, from that area and depolarizes that whole muscle. And we only need a tiny, tiny bit. Let's say we just need one particle of acetylcholine to cross that motor end plate and hit that acetylcholine receptor to trigger depolarization, therefore contraction. Now again, a tiny bit of potassium is released. Tiny bit of potassium is the byproduct of that reaction. When we come in with succinylcholine, there are millions and millions and millions and millions more particle per one receptor in concept that all of a sudden is there. So for sure, one of those particles is going to find its way to the receptor. And if it's in a normal person that doesn't have a whole lot of pathophysiology or anything, then only a tiny bit of potassium is released, just like normal. However, folks that have burns and past 24 hours, where now that fluid is shifting, and now we have a lot more potassium in the vasculature, and we give succinylcholine, and we fill every one of our acetylcholine receptors, and we have a little bit more potassium that's released than normal, adding to the already high potassium that could put them in danger. That's why that contraindication is important. But let's go through some of the other ones. Some of the other contraindications is crush injury right away. All right, right away. If you have crush injury and that potassium is now, you don't have to wait for the fluid to shift. The cells are busted and they're open and they're flooding into the vasculature. At that point, then you're already potentially hyperkalemic. And so that's where crush injury, we're starting bicarb, we're starting calcium to basically counteract hyperkalemia and be protective. And usually we're way more liberal on that when we apply that therapy. We're like crush injury, we give these two, right? Because we're trying to get ahead of hyperkalemia. Okay. So those are those two. And then, of course, if you're hyperkalemic inherently, we don't give it. And how do you know that? You know that from, looking at your your ECG, and you're looking for that tall peaked T wave. Typically that wave will get taller and taller and taller until it stops getting taller and then it starts getting wide. And at the moment it starts getting wide, if you're paying attention clinically, if you don't have like an iStat or access to a way to measure labs, then as soon as it stops getting taller but it starts getting wider, that's probably when you should at least begin to give medicine if you haven't up to that point. Because it's going to get wider and wider. It's become that sine wave. And that's way behind the eight ball. If you see the sine wave, if they have a history of renal failure or kidney issues, then time to give calcium and bicarb, which is the treatment for hyperkalemia, is probably upon you. Okay, so we have hyperkalemia we've talked about inherently. We've talked about the 24 hours post-burn. We've talked about crush injury right away. And the other one is neuromuscular problems. So any type of multiple sclerosis, cerebral palsy, any of these any of these conditions where the nerve might be firing or might not be firing, and the muscle might be working, might not be working. And so your body recognizes that, like, hey, why aren't our muscles working? This doesn't make sense. And so your body says, you know what? Let's try to figure this out. Maybe it's because we don't have enough acetylcholine receptors, up there just ready to grab an acetylcholine. And so it's called upregulation, and it's just a biochemical term. It just means that now instead of one acetylcholine receptor in this big area, now there's hundreds and hundreds and hundreds and hundreds. And so in neuromuscular problems and anything, and I don't even care to remember what they all are. I know typically you hear like one of the neuromuscular diseases and you recognize, okay, that's neuromuscular disease. But it's not just that. It's if they've been in a cast, if their arm has been in a cast for longer than, a couple days, if they've been bedbound for over 24 hours, if they are in a wheelchair, it just normally, or if they've been in a wheelchair for longer than a day or so, if your muscles don't move, your body recognizes it and it tries to figure out ways to fix it. And so it'll upregulate all of these acetylcholine receptors, and then trying to catch one acetylcholine coming through a big area of the cell so that it can fix whatever the problem is. It can move. We show up, all Billy Badass, and we give succinylcholine, and all of a sudden there's millions of particles and hundreds and hundreds and hundreds of receptors, and there's a big potassium release. So the thing that scares me the most with succinylcholine is it malignant hyperthermia, which happens in a tiny, tiny bit of cases, which we'll jump into the comments here and go through and see those people, everybody's concerns with that, which it's valid, but it's a rare thing. What scares me the most is giving a neuromuscular blocker, like a depolarizing neuromuscular blocker like succinylcholine to like a pediatric that has undiagnosed neuromuscular problem. That it's the problem's already there, and the body, like the muscles aren't moving as normal. We can't really detect it because they're little kids or they're pre-toddlers or whatever, and their body's upregulating all these receptors, and then we give succinylcholine and massively cause hyperkalemia. Those scare me. People, when we don't think the fact that people in wheelchairs, those muscles aren't working. So it all comes down to really if people's muscles don't work normally, their body is going to try to build all these extra receptors to try to make muscular contraction happen. And the problem is that causes hyperkalemia if we give succinylcholine. And so those are the ones that scare me, is the folks that have like in a cast or they're bedbound for like a day or two, or if they've been sick and they've just been laying. Like if you don't move because you're ill, your body like wonder why we're not moving as much, maybe, and it starts to upregulate these receptors. And over time, like as you begin to move more and you feel better, they downregulate. They break them down and you don't need as much. It's a crazy biochemical thing, but it's pretty awesome. Now, this is where we get into, and I just wanted to make sure we hit really fast the contraindications of succinylcholine: crush injury right away, burn injury within 24 hours, any type of hyperkalemia, which would include renal disease. If they dialyze, one of the things I'll do is I'll just feel people's forearms and biceps to see if there's a graft there. If it is, boop, not giving succinylcholine. Because what I want to talk about here in a minute is there are times where succinylcholine is perfectly okay. And I get this like, well, I just don't want to do it because of the handful of times that it's bad. And that's okay. That's a legitimate thing. And I'm not trying to make anybody, force anybody to think about using sucks. I'm just saying that most anesthesiologists, I mean, when they talk amongst themselves, they don't say, oh, we're never giving sucks. There's a perfectly good time and safe time to use that medication. And maybe, they're a little bit more safe. They have a way more experience and education clearly than Joe everyday flight paramedic. But there are times where that's safe to use. And again, the conjecture and debate is, should we be using it in pre-hospital? And that's a fair debate. I personally think that there might be times where we should use it, but if you're one of the types that don't want to use it, I get it. Not a big deal. But anyway, let's finish and let's hear what Greg has to say.
So you can utilize succinylcholine immediately after the burn in these situations. The rule of thumb is never greater than 24 hours after the burn can sucks be used.
Test questions love this. The item writers who write these evil people. I'm just kidding. I know a bunch of them, but I love you guys. But you're evil. You're a little psychotic, and you know it. So the point there, though, is that in a question, I mean, even if they say it's 20 hours ago, it's technically still safe to give. Are we going to give it in real life? I mean, that's up to you. I mean, like if we're talking about it, then maybe we're already harboring a little bit of, and then we go to rock. But we're going to get into a little bit deeper into the why you should, why you shouldn't, and just kind of show you guys the overall debate, let you guys, verbalize to us on the comment what you think or share amongst your group. But let's let them finish.
Now, the reason for this is simple. Succinylcholine is metabolized very quickly by pseudocholinesterase. And it's been in use for a long time, actually, even in veterinary medicine. So we have lots and lots and lots of data and understanding of the science of the metabolism. Like in cats, it only lasts about 5 minutes, where in dogs, it can last 20 to 30 minutes. And then, of course, if your patient has, say, liver disease, that can, like many things, take longer to metabolize. But even in all those situations, the metabolism time of succinylcholine, in anyone who doesn't have a predisposing condition, is measured in minutes.
So he's just harping on the fact that the time differential is a benefit, and is even if in patients where it's not broken down very, very swiftly. Basically, all succinylcholine does. I mean, we talked about acetylcholine and succinylcholine. Sounds similar. And that's why that the succinylcholine can sit in that acetylcholine receptor. They're shaped very, very similarly. However, acetylcholinesterase, like once acetylcholine gets there, it's like immediately gets pushed out and that receptor's back open, allowing for another depolarization within a few moments. Not so with succinylcholine. Succinylcholine is like, I don't know, imagine like, a big muscle-bound bully that sits in somebody's chair and they can't get him up. And that finally, after, 3 or 4 or 5 minutes, they can finally get him up with the help of a handful of other folks, or that he just finally gets tired of sitting in that chair and just moves. That's exactly how succinylcholine just occupies that space for longer than normal. And so we have a prolonged paralysis, and just long enough so that an individual should be able to get in there and get the patient intubated, and then all that will be removed. All that succinylcholine will be removed. The paralysis will begin to fade, and interestingly, they begin breathing again. That's a depolarizing neuromuscular blocker. The non-depolarizing nothing ever crosses that motor end plate. From the nerve to the muscle, nothing ever leaves. It just doesn't allow anything to go across, and so it doesn't have anything to cause contraction. So it has a longer it institutes paralysis by just not sending across the chemical mediator that says contract. It doesn't do that, and so it causes paralysis. But those medicines take a lot longer to clear out. So I do like that he mentions the speed of the metabolism. And so metabolism is really just a breakdown, right? Breakdown. Like for most of the time we talk about metabolism, we're talking about oxygen and sugar getting broken down into ATP and energy. This particular case, it's breaking down the components of the chemical communicators from nerve to muscle, talking about like start a contraction. If you prevent that from happening, or prevent if you prevent that from ever going across the motor end plate, that's non-depolarizing. If it crosses the motor end plate and just sits in the chair like a big bully and not leaving, then that is depolarizing, because it actually depolarized. It actually went across the motor end plate. That's kind of the difference of those two.
So that brief shift over a few minutes, say 5 minutes, 10 minutes, it's not going to put your patient in a hyperkalemic state and kill them unless they've already got something going on. And even then with the burn thing, it's a chance you're taking. It's not necessarily a guarantee that they're going to die. So, immediately post burn, if you have a bad traffic accident, if you have like an explosion or something, immediately post burn, succinylcholine is perfectly fine to use under most people's idea of the standard of care. Let me put that caveat in there. But
pretty sure he's throwing that out there because he knows that if he's about to get attacked from the ones who sucks, or we shouldn't be using sucks in pre-hospital. There's a lot of people that say that. Again, I get it. I get the argument. And if we are ever flying together or working together, and we talk about, hey, what meds we want to use, I usually bring it up at least to get in conversation. And I'll give you a couple of instances when maybe sucks might work as an option. But there's no one set of medication regimen for every patient. Right? We have to make decisions at the patient right then at the time, based off science, based off what we see clinically, and really weighing the risks of these medicines, right? And so that's where that comes into it, where it should open the door back up for at least consideration of sucks. Now again, I don't use sucks that often, but I do use it every once in a while. And the idea is like, this is save time. What if we I never want to be a one-trick pony. I never want to just do one way every single time. We need to be able to improvise, and I stole that from a trauma doc that I used to work with a long time ago. So he infused that into me, like, be able to improvise, because sometimes the field, he said the hospital systems, in the hospital when it's still chaotic, they'll throw you some curveballs and you might have to improvise, but the field will throw you bigger curveballs because it's not a set standard safe place with a bunch of hands and a bunch of resources. Sometimes you have to improvise. So be ready. And that's the only reason I bring in, maybe we don't throw succinylcholine away, but and we'll get a little bit deeper into this here in a minute. But I know he said that point so that he knows the commenters are going to come in and come for him.
But in EMS, they do not like for us to facilitate with drugs like vecuronium and rocuronium. Personally, I don't see the problem with it. You do have to have some experience and some understanding of your non-depolarizing paralytics, how long they take to work, etc. But you can facilitate with those drugs. And the reason I say that is that's probably going to become the standard of care over the next several years.
Cool thing about this comment, I think he's dead on accurate. And when you look at the comments, we'll look at the comments here in a second and see all these folks like, we're at risk for malignant hyperthermia, we're at risk for hyperkalemia and all this stuff, and so we need to use rock, we need to use vec, and these drugs that are safer versus succinylcholine. That argument is valid. And let's go back 10 or 15 years. People were terrified to give paramedics the ability to halt somebody's ability to breathe. And rightly so, because we were just starting to get it. When I left as a flight paramedic, I worked at the Level 1 hospital in Mississippi for like 6 years, and this was from 2005, 2010 or 11. When I left, we medics weren't allowed to push paralytics, and now we can. And so this change over the last almost 20 years has been a good one. Now paralytics are in more and more hands of paramedics, and the why is that when we go to RSI somebody, there's a lot of drug, drug sequence intubation or the DSI, the versus RSI kind of mentality, and sometimes that works, and sometimes that's just fine. The science shows that a paralytic helps first pass intubation success. And where do we want that? Everywhere. We want that in the field. We want that in the hospital. We want first pass success, because the more times that you have to go back and look, the complications grow exponentially. So you want to set yourself up for success in the very first time. Okay, so the thought process is, well, we don't want them to feel this or remember this. So we give a pain medicine, we give a sedative. Some places don't give both of those right away. Some do. Not the point of this conversation, but we give a sedative, we give pain medicine so they don't feel it, they don't remember it, or at least they're out, and then we give a paralytic to relax, to paralyze all these muscles till they're so they're totally flaccid. And what that does is it allows us to put that big metal spoon and pull the mouth open so that we can basically lift up over one of the tubes to see the top tube, right? The airway. And so it's when the muscles are flaccid and paralyzed, it's way easier to move this anatomy. If they're sleepy, and let's say they're well sedated, maybe they're sleeping fine because we've given a sedative. These muscles are still going to be contracting, and there's reflexes that happen, like when you go and try to pull a muscle, it because there'll be a little bit of tone there, it'll be harder to manipulate, and that reduces your first pass success. So if you're going to do drug, DSI, then, or, drug sequenced intubation, then make, the thought process is maybe you give a little bit more than normal. But that gets into a big conjecture now too, is like, are we giving too much medicine? And, rightly so. I get the arguments. I also see that in the field, we have way more stimuli than in a nice, calm, controlled environment of an ER or an OR. In the field, we have heat, temperature extremes. We have noise extremes. We're constantly rattling and banging our patients around as we move from one place, one vehicle to the other, and one environment to the other. Anyway, that's another conversation. But the bigger point here is the fact that paramedics, we've been using this now. Paramedics and field nurses have been using this out in the field for 10 or 15 years now, and we're getting better at it. And so there is clearly a switch of folks going now like, no, we feel comfortable doing rock. Or VEC versus the succinylcholine and some of its risks. Again, I think that there's some safety in succinylcholine if you are thinking through and you're ruling out known contraindications. And it gets to the point like, well, I don't know if they have this. Okay, great. Then go with a non-depolarizing, right? At least you're thinking it. There's times that I use sucks again because I don't want to be a one-trick pony. I don't want to just use rock and one or two other meds. I want to always be ready to improvise in the case that I have to improvise. But he's right, and the switch is happening, and I would anticipate more and more folks getting away from sucks and just using the non-depolarizing. But again, talk to a couple. Reach out to make sure you do your own research. Look up on UpToDate. Look up on the internet. Call your medical director. Talk to anesthesiologists. I mean, the anesthesiologist. I haven't met one yet that has told me that, oh, we don't use sucks in the OR. Well, they totally use sucks in the OR. They go through the process. A pretty safe drug. Malignant hyperthermia is a very, very small risk. Now, once it happens, well, then that's pretty bad. Hyperkalemia, we try to prevent. We don't give it to some of those contraindications that we talked about so that we don't cause hyperkalemia. But sometimes you can manage that ahead of time. And sometimes that's happened where they will manage like a 5 or 6 and still use succinylcholine. Of course, they way more experience at it. And that's not saying that we should adopt everything that anesthesiologists do, but we need to look at all the information and make best decisions. Again, I think that if you're telling me that there's too many risks with succinylcholine, I can't argue too much on that. There are risks, and if you don't want to give it, I get it.
I hope that answers your question. If you need any more details, just hit me back in the comments.
So, comments. Very good. Let's go through some of these. I got 67 here. So, ICU nurse, can you elaborate on why medics don't use rock? This was a good little comment. So, this is clearly a medic. I do almost all the time. And I like that. That's almost all the time. I'll take that. I'll take that. What I don't like is being closed-minded where I won't use it. And then my questions would be, well, if it is safe in some situations, why wouldn't you? And if you don't feel comfortable, again, that's a good argument. I'm not going to argue that at all. But saying that we shouldn't do it, that gets a little mucky. And then this guy says they do. Rock is too slow, in my opinion. Comes out faster than Vec. Okay, so this is a ICU nurse talking that has to deal with these patients, and this is really, really good. Rock is too slow, comes out faster than Vec. So she doesn't like the onset, and it comes out faster than Vec. So that means that person has to deal with the patient, a lot more, where the Vec would carry him over a little bit longer. So, I mean, that's just good information. In transport, I really want him intubated, or I want them paralyzed for intubation, and then I will reparalyze only if we can't keep them sedated to the point where they're not reaching up and grabbing stuff. I'll try to do that, but sometimes you need to. And I know all the studies talking about ventilator-assisted pneumonia makes sense, but we have to get them intubated. And first pass success, the studies show that first pass success happens with a paralytic on board. And rock is more expensive. Okay, maybe so. I'm out of that game. Rock is slightly slower and hangs around longer. So this is like a little bit of an argument there. Comes out faster. This person says comes out faster and says it hangs around. For me, in my anecdotal meandering experience, I've seen rock last, I don't know, like if you give a 1 milligram dose, the dose is 0.6 to 1.2 milligrams. And some anesthesiologists will say that we probably need a half that. But again, another conversation. Current dose, 0.6 to 1.2 milligrams per kilo. And if we would keep it simple, we'd give 1 milligram per kilo. That would last about an hour. So if we half that, if we gave the 0.6 or essentially a 0.5 dose, that will last about 30 minutes for their weight. And again, that's anecdotal. That'll also change a little bit depending on their metabolism and hemodynamics and how revved up or revved down their body is based off condition or medicines, but important there. I was always told sucks wasn't supposed to be given in burn patients. They're ultimately just being conservative. They're like, well, I don't want to. If it could, do we even get into the hour? If it's 1 hour, if it's 10 hours, if it's 23 hours. So a lot of times people will say just don't give it because we don't know what. I mean, we manufactured that 24-hour number. I mean, based on science and medicine, hopefully, that's actually something I just thought about. I've never seen the study that says that, but I know that a lot of stuff is based off like what we know medically, from normal physiology and other pathophysiologies of burn. But nonetheless, like if it's not given in burn, then they're just being a little bit more conservative. If you don't carry these meds, what would you suggest? Learn how to facilitate analgesics and benzos. Not ideal, but works. Totally agree. You got to do with what you got to deal with what you have. And conversations like this, go to your medical director and just be clear. Like, hey, why aren't we doing this? What is your fear? What is your worry? Can we build a training program where we can get information, practice it, then display to you that we can do it safely, and then you rigorously, we choose those calls to review to see if we can actually do it. Again, that's a way. There's a bunch of different ways that you can facilitate that, but having these conversations is important. But yeah, you can do it with analgesics and benzos. You got to what we used to call snow them. You got to get them, basically put them in the K hole. If you don't have ketamine, you put them in the Versed fentanyl hole or whatever hole you can snow them down into to get them at least somewhat relaxed, so it improves your first pass success. Again, not ideal, and I agree with them there. Why would you choose sucks over rock considering all the potential downfalls of malignant hyperthermia? How would you know the patient has history of assault? Okay, so great. So answering here, malignant hyperthermia happens as a weird result of some different types of depolarizing neuromuscular blockers. Used to happen a bunch with the ones that were gas-based, that were vaporized, but it also happens in sucks. And this is a weird thing that can happen. It causes a lot of calcium release. Calcium binds actin and myosin, and we have a whole massive, contraction, which, a lot of contraction and a lot of metabolism. So instead of like binding calcium and then releasing it for like, if I'm doing my muscle, contracting my bicep here, then it'd be like if you just stayed there and you just kept contracting it for a long period of time. That causes a bunch. First off, you have to have a lot of sugar and oxygen to do that, so it metabolizes ATP, and metabolize ATP. What's one of the byproducts? CO2. So we have this massive CO2 spike, massive heat spike, and we got to fix them right away. The fix is dantrolene, but we're never going to carry that in the field because first off, you need like vials and vials and vials of it. It's kind of like Crofab almost in the amount of volume you have to give to correct it. What we're going to do is going to ride it out typically in the field, which means you need to get like a bunch of cold packs and pack their axilla, and treat hyperkalemia, which typically happens because now their muscles are really rigid and they're going to start popping their cells because they overuse the cell, and then the cell explodes, and then potassium can leach into the vasculature at that point. And I've had a case like that, and I'm going to do a video soon where I really get into that case. But let me know what else you want to talk about there. But again, the point is, like, this is a very, very small, very rare occurrence. And I believe it's like in the 1% of the data. This is a safe drug if you have cases where like somebody's blown their face off, but they're still, with a shotgun, they're still like looking around kind of, and that we've seen those, and like, you're like, the anatomy's all weird now, and I don't know. So maybe if you're going to try to put a tube down, like, a lot of times you can just see it, but then maybe you do succinylcholine, especially if they're protecting their own airway. It's those cases of like angioedema or stuff where like, hey, let's have them come back online if we can't get this, right? And those are some of the cases that you might want to use that. As an RT, don't give them a large ET tube as the tissue will swell. That's a great point, man. That's really, really solid. Plan there of like smaller tube, because that tissue is going to swell, and that tissue could help that, get real tight around that tube. So that's a really, really good, that's a veteran level thinking there. So we all think, we got to get the biggest tube. I got the 8.5, I got the 9. In cases of burn inhalation where, the original question was, what would be the best way to intubate a burn patient who's alert yet as inhalation burns? And she actually answered if this person wasn't asking about succinylcholine, then she's answering the other line of thinking, like, just the how, what are some pearls to do it? And that RT had a great point: smaller tube, maybe a 6.5 or a 7 versus a 7, 7.5 or 8. Because that tissue is going to swell. And then the thing is, when it's like the moment you walk in and you see singed nasal hairs, especially if they're hoarse, boo-boo, you better start knocking it out right now. I mean, you better start getting everything ready. Get your cell phone out, call them, say, sir, we're going to have to, your airway could swell, so we're going to put you to sleep, put a tube in. Get your cell phone out, let him call his family. I mean, that literally happened to one of my very first calls as a paramedic. And the flight medic was like, give him your cell phone, let him call his family. Because this guy was very badly burned and probably wasn't going to make it. And he didn't. And so, but we were able to tell him, like, it's bad. It's possible that you survive, but why don't you call your family and tell them you love them? And it's awesome by that flight medic to do that. And so I gave the guy so the point there is, what would be the best way? Soon, fast, quick, in a hurry. Get everything laid out, prepare for it, knock that out, because once that swells, then you're gonna have, if their airway swells to the point where they can't breathe and they go into hypoxia and start to brady down, you're already way behind the 8 ball, and you're gonna have to crike them because if you can't intubate because the airways are too narrow, and you can't ventilate because the airways are too narrow, then you got to crike them, right? So I would get my airway stuff out and have my crike kit right there next to me, try to put off some good juju, find your landmark and make a dot so you don't have to go search for it later, or make like a little line on their neck with a marker so that you don't have to do that later. So some of the things to think about there, if you were at all worried about the burn, then yeah, don't use succinylcholine if you don't want to, but have your plan. And I think that side of the question that Shade Tree answered, about the paralytics, but the side of, what and when, like now, do it quick. Too many medical directors out there way behind the times. That may be true. There's also a lot now that are coming out of it. There's a lot of residencies that have EMS fellowships, EMS-driven emergency medicine residencies, and those have been instrumental in getting more. I think that's really why we have more people out there intubating, is because we understand it's unsafe, but so is almost anything we do in emergency medicine that we're granted the right to do as paramedics and flight nurses and flight paramedics. So I think that there's a lot of those trained folks out there giving us a little bit more ability to do some of these skills. I thought sucks was bad for burns because it caused fasciculations. Well, that used to be the thought for like polytrauma patients, where maybe like the bones as it fasciculates because it's depolarizing, succinylcholine that is, as succinylcholine depolarizes and it causes fasciculations. And so the little muscles kind of just quiver a tiny bit. And like if you have bone shards, you can jam them together. That was the thought there. Not so much bad for burns, but and then somebody I think comments about like how to do a depolarizing or defasciculating dose. You can use Versed. So Versed and Ativan won't do the job as well. I mean, it'll minimize the convulsions, like not really convulsions, the fasciculations. But this person here says you could use basically a 10% dose of rock or sucks to we call that a defasciculating dose. And so instead of sucks, I wouldn't give sucks for it, because sucks is what causes the defasciculations, because it is a depolarizing. Rock is a non-depolarizing. So that's what we used to do, is we used to give rock or VEC 10% dose right before we gave the big bolus of succinylcholine to prevent the fasciculations. And every time I've seen it, I mean, the hundreds and hundreds of times, it starts at the feet and kind of moves up, and last thing is their head, their skin around their eyelid will be the last thing to go, and that's where we start, rubbing their eyelashes to see if they have any response, and that's when we kind of know that they're basically pretty paralyzed. So the point there is defasciculating doses, that we quit doing that a long time ago, just because it just didn't seem like it was helping that much. And they have had a couple studies out that it doesn't help, doesn't hurt. So what else we got here? Anything good? I'd nebulize lidocaine while setting up, Versed at a time. Oh, this is solid. Okay. So, and nobody commented on this. So this guy's like nebulize with lidocaine. So lidocaine is a pain medicine too, right? So if you nebulize, then you're gonna it's gonna be a little pain, a little pain decrease there. It also will reduce that swelling a tiny bit. Versed and etomidate for induction. I get where you're going. I do 20 to 30 urgent or emergency tubes a year and rarely paralyzed. So and I get that, and there is a way to do this. I'm sure the most successful, right? So the research says now that a paralytic improves first pass success dramatically. I know that sometimes he says he rarely paralyzes, and so he's probably pretty decent at this. I'm taking it at his word. I know people out there can conflate some things sometimes and speak in hyperbole, but I'm going to take him at his word, and I get it. There probably is a good recipe. That's probably for folks who are better at it versus folks who aren't as confident or as good at it, at intubation and the RSI and the whole process. And then so maybe we let those folks paralyze. Now, if you're really good, you can do this. I get it. But when we have a angioedema case, nebulize lidocaine, nebulize morphine, those are options, because it will help reduce swelling, reduce pain, and morphine is an antitussive. So some of those are way outside the box thinking that I've seen used before. But to get somebody intubated that was, in this particular case, angioedema, and we got him nasally intubated. The team I was with was pretty awesome that particular day. All right, so the best way with an ET. Okay, yeah, I don't want to be sarcastic. I don't get all the sucks hate. Me too, dude. I get it. And here's the MH risk: malignant hyperthermia, maybe a little bit, but not as much as you think. Hyperkalemia, you can rule those out usually pretty quickly and easily. They're just risk managing risk, and that's perfectly fine. That's the argument I can deal with. The value of MH is very, very low. Hyperkalemia is a little bit bigger, but probably if you eliminate the contraindications, then it probably is small or smaller than the MH risk. Anyway, I think we've hit a good portion of this. The biggest thing is, how do you intubate the patient who's awake and has inhalation injuries fast? And maybe that's the time, if you don't normally give pain medicine with and a sedative for RSI, maybe do it that time. They already need pain if they're burned anyway. So give them some pain medicine. Make sure it's adequate like that it's helping them. Give them the upper end, potentially really consider that upper end of medication, of sedation, because you don't want them to remember or feel it or remember it. And enough pain measures, they feel way less, and then really consider a paralytic to maximize your first pass success. Choose a smaller tube. That was a great pull by that RT. Maybe a 6.5 or 7, like on average adult, but make whatever age you're using a tiny bit smaller, maybe 1 or 2 halves, because it will swell around that. Be ready to crike if you need to, and know that that's one of the few times it's like if you get in there and you're like, man, I can't get them intubated, and then maybe you've pushed on that tissue and now it starts swelling a little bit more and just and so now you can't ventilate with ambu bag. Drop that immediately and go to crike or needle if it's a kid that's 8 or less or 10 or 12 or less, wherever your system determines to give a needle crike versus surgical crike in your patient. Be ready to do that, and I think that's a big thing. And of course, all the depolarizing, non-depolarizing information given with succinylcholine versus the other non-depolarizing meds. Make sure I said that clearly. Succinylcholine depolarizing versus the non-depolarizing medications like Rock and Vec. Well, I hope you enjoyed that episode of Viral Unpacking. This is one of my favorite topics to really get into. It's something that, airway, before breathing, circulation, and now, of course, CBA and or all the different March and trauma stuff, but airway is very, very important. Sometimes we can kind of put it off a tiny bit, and ventilate from a basic standpoint before we have to get into it. But getting into the nitty gritty of how to and why and when, and we need to have more conversations like that. More conversations like you come back from a flight or a call, and then you discuss it with everybody. That's some of the best learning out there, and that's what I kind of wanted to start this podcast doing. And I hope you enjoyed this episode. If you have any questions, reach out. If you have any comments, leave them in the, drop some comments. Let me know what you want to see next. Let me know if we got something right or wrong. Not perfect at all. And but otherwise, y'all take care. Be safe out there. See you next time.